Cardiosource World News is here at ACC 13 Scientific Sessions. We're pleased to have Dr. Giora Weisz of Columbia University Medical Center with us to discuss some of the complications and problems in modern percutaneous coronary interventions. Thanks for being with us. What was the problem that you were looking at?
It's a pleasure to be here, talk to Cardiosource. We were looking at actually how PCIs, coronary PCIs, are done in the cath lab. That has not been changed much in the last 40 years since it's been introduced. And there are two major groups of problems that we are still facing, and they put obstacles in the way we practice interventional cardiology. One is the standardization of the procedure. So everybody does the procedure a little differently, and we face problems that the intravascular devices, they move frequently, they are not stable inside the coronary arteries, the positioning is not always optimal, and we select our devices sizes, mainly the stents, mainly by eyeballing. And obviously, with eyeballing, we made some mistakes, and some studies showed that between 10 to 20% of procedures need an additional stent just because the first stent that was selected was a little too short. So there is not the right utilization of the resources. In addition to that, working in the cath lab has some occupational hazards. We are exposed to radiation, and multiple cases that the radiation accumulates. There was a recent publication that is very bothering about a cluster of left-sided brain tumors in interventional cardiologists, interventional radiologists. Yes, we don't know what is the numerator and we don't know what's the denominator, so we don't know what's really the size of this problem, but everybody will agree that this is bothering. And nonetheless, we know that interventional cardiologists have higher frequency of cataract, posterior lens opacities that are basically cataract that accumulates with longer work. And for interventional cardiologists, we have the posterior lens cataract at a younger age and much more frequently than any other profession. So in order to protect ourselves from radiation, we wear those heavy lead apron that cause us spine problems. And recent survey that was done a couple of years ago by the Sky Society showed that after 20 years of practice, and that's not so much, like everybody practices more than 20 years, 60% of us have spine problems that cause loss of working days. So this is a major occupational hazard to work in the cath lab. That's not simple. So in trying to give answer for both the standardization and the stabilization of the intracoronary procedures and take better care of the operators, that if you treat them better, it will also translate to better patient care, I believe. There is a remote control angioplasty system. The one that I've been working with and doing clinical research on is the Corpus 200 system that was done by Corindus. I have any potential conflict of interest, by the way, with the manufacturer, just my academic interest. And so we did some very interesting studies. We did a short first-in-man study of showing the safety and feasibility in the first group of humans. And then we went to do the large pivotal study that is about to be published in JACC. That was a 9-center, 164 patients that had their full interventional procedure, all the intravascular part, done by a remote control robotic system. So just a short description of the system. So this system has two components. It has a small robotic drive, a sterile cassette that is connected to the guiding catheter and loaded with the balloon, wires, and stents, and actually has the engine to move those intravascular devices inside the body with forward and backward maneuvers, rotational maneuvers, and that's being controlled by a remote, what we call a cockpit. So where it's a small cockpit that is shielded from radiation, that the operator can sit without the heavy land, very ergonomic, sitting close to the screen. So there is also the improved visibility of, you don't need to lean forward to see what's going on a couple of feet in front of you, but it's really sits very close. And you do the whole procedure with 2 joysticks.
What kind of results have you seen from these procedures?
So out of the 164 patients that were treated with the system in this pivotal study, the procedure was completed. Everything was done by the remote control robotic system in 162 patients out of 164. Only in 2 patients we needed some manual conversion because some technical difficulties in a very probably wrong selection of very difficult cases. The conversion that was done within seconds without any clinical consequence. So the change is immediate. We looked also some other safety features. There were no mortality, there were no device-related complication, no target vessel revascularization, no stent thrombosis. There were only 4 cases with mild asymptomatic, no EKG changes of mild CPK elevation. That's regarded as a non-Q wave myocardial infarction. So what we call the primary endpoint of the clinical success, completing the procedure with the system without any even subtle complication, was achieved in 97.6% of the patient. So this is really very, very reassuring. We also looked at some subgroup that compared them to a cohort of patients with the same inclusion-exclusion criteria, comparing them that were done manually by the same operators during the same period of time to make sure that we are not trading operator safety for patient safety. And luckily we found that all the important parameters of radiation exposure and the use of contrast media not just was not higher to the patient, but actually trended to be lower to the patient, even using a very new system with very small experience. We looked also at the learning curve. And the learning curve is very quick. So an interventional cardiologist, he knows the neighborhood. And after 3 cases, all the operators perfected and had shorter procedures time, less radiation exposure. So it's very easy. You can learn. It's very intuitive. You can learn to do the procedure very quickly.
Do you expect to see this coming into practice more?
I think this is the next big thing in interventional cardiology. We just started. Based on this study, the system was approved by the FDA. And now a couple of centers that's starting to use it routinely. I'm using it routinely on my cases and have done already a variety of complex procedures with whether it's femoral access, radial access, native coronary arteries, and SVG using a pressure wire, even a case of a myocardial infarction, left main. So really it gives you probability and very quickly when you figure it out in 3 cases what needs to be done and how to use the very few tricks and tips, you can do a lot.
Excellent. It doesn't sound like any downside and a lot of upside. The study will be coming out in JACC in April. And for CardioSource World News, I'm Dan Keller.